if we're aspirational, hope that all people will be successful, excellent cardiologists, excellent nurses, excellent team members. If we start with that, then we can start being creative about, well, what does he or she need to reach that goal? I actually see how when you start with a desire or equitable outcomes, whether it's clinical or in the workforce, you get really creative. When you talk about diversity, there's a fair amount of data that says that diverse teams make better decisions. Those decisions are not without more conflict, and they take longer, but they're better.
You're listening to Parallax from Radcliffe Cardiology in association with makeadent.org. Here is your host, Ankur Kalra, MD.
Hello, everyone. Welcome to another episode of Parallax. Welcome to another Monday where we have a great guest on the show to talk to us about topics which are topical of interest, not only academically or from the perspective of patient care, but also as to how we live our lives as cardiologists and our careers and advancement in our careers and career development and some of the challenges and obstacles that we all face and sort of are looking for platforms to have these conversations and discussions. So with that introduction, today's guest needs an introduction. Her name is Dr. Sharonne Hayes. She is Professor of Cardiovascular Medicine at the Mayo Clinic. She's a cardiologist, of course, and we were just talking offline. She now is the department's vice chair for academic advancement and faculty development. Topic which I think we're going to broach in our discussion today. And she's also the immediate past director for diversity, equity, and inclusion at the Mayo Clinic in Rochester, Minnesota. So with that introduction, Dr. Hayes, welcome on the show, and thank you so much for doing this for us. I know we've been wanting to record this for the past couple of weeks now, so I thank you for your flexibility, and all of us at Parallax are delighted to have you on board.
Well, I am delighted to be here, and I'm also excited to talk about this topic, which I think we certainly haven't solved.
Absolutely. So, without much further ado, let's just dive into, I think, our first, topic of conversation, which, I'm sure you are at the center. You're sort of at the fulcrum or the center of this as vice chair for academic advancement and faculty development. And this may be a bit more rigid than either you or may like for us in cardiology, but talk to us a little bit about career flexibility for cardiologists, and I think as an extension to that topic, I'm going to also have you shed some light and educate us and educate our audience, the vast majority of who are cardiologists in practice or early career or advanced practice providers, as to how you brainstorm questions around parental leave, for example, which I think falls under the rubric of career flexibility. So I'm going to stop here and have you, enlighten us on some of these vexing topics.
Yeah, well, thank you. I personally have given this a lot of thought because of over my career, where I had raised 2 children, married to a cardiologist. I didn't have that. What I always sort of was jealous of those people who had the flexible spouse, right? Who had a flexible work job. And so have really thought a lot about flexibility. I think one thing I want to start with, though, is whenever we talk about flexibility or parental leave, we immediately go to reproductive age women and their need and desire to bear and raise children. Where I can't think of a person among us who would not want more flexibility, right? Flexibility can just mean autonomy. Flexibility can mean where you work or what hours you work. Now, as you acknowledged, when the patients are there, whether it's in the hospital or scheduled in the outpatient, we may not have much flexibility that day, right? We're going to see all those patients. And that's why I like to talk about career flexibility, because we all, medicine, and particularly academic medicine, has really got us pretty rigid in what we need to do. Say you go into academic medicine, you finished your fellowship, you go in, and many have a tenure up or out in that first 7 years. So you come out of your fellowship where you need to then be the most productive if you're going to be successful, right? Otherwise, they write you off and think that you're kind of a slacker or not really committed to your job. We're back to the reproductive age women and men, but you figure at that point, you're probably in your early to mid 30s. And if you have not already reproduced, this is your time that you actually have to be most reproductive. And those two, academic productivity, clinical productivity, and reproduction, those clash. And that is the heart of, because of the rigidity of medicine, is the heart of why many women lean out, or they are written off, or they go into practices that they might not really want to, because at that time of life, which is the only time of life they can bear children. And one thing I've really advocated for is, if you look at career arcs, I had the same feelings. I thought I'm falling behind my male colleagues when I had little children, because I did work less than a full FTE. I stewed about it a lot. And I look at myself now, I said, that was a very short time in a very long arc of a career. And I sometimes call myself a late bloomer. I became a full professor later than some of my male peers. But I got there, and I have been very satisfied with my career. So looking at, instead of marginalizing individuals, is let's let men and women early career, if they need to lean out, so to speak. And then we have bright flashing lights. So when they are ready 5 or 10 years or 15 years down the road to come back in and fully engage, whether it's clinical practice or academics, that we have a welcome sign up for them, and we have ways to reintegrate them into that process. So that was my passion, because that directly affected me. I felt like I was behind. But I think as I've looked at it, we need to look at where career flexibility may help us at the other ends of our career, or mid-career, where we just want to try something else, right? We want to dabble perhaps in industry, or we've maybe never done research, but we want to get involved in a clinical trial, and we're 10, 20 years into practice. We ought to look for ways that we're not pegged in. I think I've given more thought as I'm farther into my career about the kinds of things that my senior colleagues have to offer us. And it may not be taking call every fourth night, right? We know that there are some cardiology practices in the US that have contracts where somebody later in career says, I'm 62, can I stop taking STEMI call? I'll do everything else I'll do. And their practice, the way it's set up, no. The answer is no. It's either all in, do everything, or not. To me, that seems like very short-sighted, because that individual can teach, can mentor, can bring in patients, and has a reputation. So as we take a step back and maybe shake off a little bit of that rigidity about, you got to do this step and then this step and then this step, one after another with no pauses, I think all of us, and particularly those of us in cardiology, should take a step back and see what would be wrong with working 0.8 for a few years while you raised your children, for men and women, and then having ways where we welcome individuals back in. What would be the harm of somebody who is 65 but still wants to work but not take STEMI call, to carve out a way that is appropriate, fair to all the partners, economically, that we can do that. So I'll stop there, because I talked a lot, but as you can tell, I have some passion around this. And what we're seeing is that it's not just reproductive age women, it is their spouses, it is people who want a life, or who have to care for parents or other family members.
Yeah, absolutely. No, we want you to talk as much as you can and as much as you want to, because clearly you've sort of led the space for the field. You've written seminal statements and papers representing the American College of Cardiology, and we can learn more as a field, and as members of our own either community-based practices or academic practices, to sort of usher in these conversations amongst our peers and with our administration, that this is something that is a requirement, is not is just not a coffee table conversation, but but is something which is a requirement, and is something which is imminently needed, uh, uh, for the well-being of our peers. And I as your role, as vice chair uh, in faculty development and academic advancement, ha- enlighten us on, maybe give us some scenarios, without obviously identifying the individual, where you felt as if that individual was perhaps um, being unfairly assessed because of certain life scenarios that occurred in his or her life, and how in the traditional hierarchical, academic setting, or maybe even a community practice based setting, um, that proves to be a downer, like a hurdle. Also um, sort of takes the enthusiasm away from contributing to the field.
Yeah, I've even I've heard it from colleagues. It's less about my role, and I think a little less about our own department. But I've I've heard comments where people are talking about a group of people, whether it's in our department or others, and they said, "Oh yeah, she decided to work part time. She probably doesn't have time to be offered that leadership position that's coming up, even though we think she'd be perfect for it." That's a real life, right? We assign that person who's either decided to work part time or perhaps just they're working full time, they're working full bore. But we, when we're looking out, say, how does she or he manage all of that? He's doing 3 research projects. He's, an amazing interventionalist, or she's got 4 kids and wow, she shows up and is excellent. And somehow we say, well, their plate is too full. So let's decide, and you can think about this as being almost a little paternal. We don't even offer or consider that individual because we think they're overburdened. This is something I regularly talk to leaders about. Don't assume, don't say no for them, because yes, they are super busy, but they also, you have just said how capable they are. And they might so want this opportunity, whether it's a leadership role or a chance to learn or be part of a research project, that they would figure out how to manage all of those other amazing things. So that's a small example that I've seen happen over and over again, where somebody observes that somebody seems so busy, and often it is a younger woman, and often it is a very well-meaning leadership team, who says, "Wow, she's already she's already really busy. Let's pass and have somebody else look at that." So that's that's sort of one aspect, and I think the so you can imagine if that was early in the career, and then it went to somebody who quote didn't seem so busy, that would be the start of multiple incremental things that got because they got passed over for that, never even offered to compete for that role. They may not be then prepared for that next role. And so I encourage folks when, particularly leaders, and I counsel leaders at my own organization and talk about leadership to others, is one, don't say no for someone else. If you think that they would be great, let them tell you no or not now. I also teach individuals, particularly our younger colleagues and our fellows, that they can say no and how to say a mindful no rather than a mindless yes. Because that too is the flexibility to choose how you are going to use your time. I have young faculty who say, so and so, Dr. So and so, senior person, he asked me to be a part of this project. I'm not really interested, or I don't really have time right now. I've got 3 other projects, but I can't say no to Dr. X. And, I push back and I say, actually, you can and you should, because you already have some other priorities. I give the example, I say, I don't really remember the people who said no to me, but I remember every single person who didn't complete a project, right? Don't say yes and then don't complete. Say not now, or there's many ways to do that. So I think there's flexibility in both being able to say yes and the way we view people who are very busy and accomplished. But I think another part of flexibility is there are only so many minutes in the day, and it is 24 hours, and reframing yeses to when you say yes to something, you are by default saying no to something else. And that might be sleep, and it might be spending time with family. It might be reading an article that's important for you and your development. So when you frame saying yes as saying no to something else, sometimes it helps you with that balance. So that's individual advice I give to folks.
Yes, something you said there, which actually really resonated with me, and having had the opportunity to mentor, residents, is that you don't really remember who said no, but you actually do remember people who said yes and never completed the project. That is such a crucial feedback for the residents and the fellows in training or postdoctoral fellows who are listening to this. Keep this just crucial pearl in mind from Dr. Hayes, and I thank you for saying it the way you said it, because I've never actually thought of it this way, but it's so profound the way you said it. And I think it's sometimes these are just blind spots. We're in that phase where we are all still learning how to approach established faculty and how to get projects underway, and we are truly willing and hardworking and earnest and eager to get things done and get ourselves published, that we somehow have these blind spots we don't really think through. So thank you for bringing that to the fore. Um, I'm gonna switch gears here a little bit, and have not the fact that we have you and the privilege of having you on the show, and I know that you've done even research in this space, and is something which is very important to you, even in your existing role, is the topic of diversity, equity, and inclusion. And now, I mean, this sort of has become, unfortunately, in my opinion, has become a political issue. So we're going to keep politics aside, and as physicians and clinicians and researchers, talk about or discuss the importance of diversity, equity, and inclusion in medicine. Um, I know that you've led an enterprise-wide effort, on behalf of the Mayo Clinic, for 10 years, even through the pandemic. So, educate us. And well, first off, I think it'd be enlightening for all of us to hear from you, how you think about these terms, what these terms mean to you as a physician, and as a researcher, and then as a leader, and how you sort of go about doing what you do now as vice chair for academic advancement and faculty development, keeping these 3 terms, words, or principles in mind.
Yeah, let me just start with, because I've given this a lot of thought over the years, because I would sometimes be asked, like, what's a cardiologist doing being in your role, for instance? And so I reflected on some early life experiences, but honestly, I think it's really helpful it has been very helpful as I have been trying to either explain these concepts or get colleagues to think about them in a different way, is to describe how I came about working in heart disease in women. We're not talking about that today, but that has been, my area of expertise since very early in my career. I founded our Women's Heart Clinic back in 1998. So think about that. That's before Heart Truth. That's before Go Red. Yes, I am older. But that came out of, I would be sitting in my office, and we can give other parallels today. I would be sitting in my office with a woman with the same, and I had men and women I cared for. And for the women, when I'd sit with her, the medications didn't work in the same way that the clinical trials had told me they should work. The diagnostic testing was not giving me the same answers. The prognosis was different, and the diagnostic test, even coronary angiography, was sometimes not as helpful. And when I would tell a male patient, I'm going to prescribe you this medication, I'm going to do this test, I was pretty confident that the medication would work the way it had been shown in clinical trials, and not for women. So and the women's outcomes were worse. And in fact, at that time, there were the deaths among men from cardiovascular disease were taking a deep and steep dive over the decade before, and women's was going up, right? So we had an inequity in deaths from cardiovascular disease, and we had an inequity in knowledge. And it appeared to me in my little brain that unless we advanced the knowledge about taking care of and understanding women's heart disease, equity would never happen, right? Women's deaths were going up and men's down. So if we think about how in healthcare we want health equity, I like to say health equity might look like that every patient who came into my ED and went to my cath lab with a STEMI, that if we say the reference is a middle-aged or older white man, that every Black, Hispanic person and women would have the same great outcomes. There isn't a listener of this podcast who wouldn't want the same thing at their organization, that everyone who came through their door would have the best outcomes. And so if we know we have knowledge gaps, so I start there because I think we can all agree we want equitable care for our patients. We want equitable outcomes. And in the case of heart disease in women, sometimes we know now we have to treat them differently. For instance, they have more HFpEF than HFrEF. Well, we didn't have a drug to treat HFpEF until about 2 years ago, but we've got dozens so focusing on bringing up our knowledge, bringing up our skill set, and improving the health of all people is a lauded goal that no one would really argue with. I mean, they can argue with me all day, but I think that they wouldn't have much argument because in their own organization, they would want everyone to have great outcomes and wouldn't want anybody to have less great outcomes, and they would try to fix it if they did. So if we switch gears more to the workforce, then we look at, well, don't we want women and people of color and folks who come into medicine as employees, as physicians, as cardiologists, to have the same great career outcomes, so to speak, as the people who came before them, which in cardiology was largely men, right? When I went into cardiology, there were several things that people would tell me to dissuade me from becoming a cardiologist. One of them was that it was an all-male field, and at that time, only 6% of cardiologists were women. Also, there was going to be a glut of cardiologists, and I probably wouldn't be able to find a job. That was before all of the interventions that we do that require a cardiologist to be right on site. And I think when we think about equity, if we take my clinical example where sometimes we may have to treat some groups differently in order to have an equal outcome. For instance, women have more bleeding when they go for STEMI. So what does that mean? We need to adjust anticoagulation. We may need to decrease the size of our stents and our catheters. So we have to treat them a little bit differently. We may need to treat, for instance, women in the cardiology workforce somewhat different. Remember, women are the only ones, at least currently with our current science, who can bear children, or those with at least individuals with a uterus. And so those individuals are probably going to do that, or the human race would die out. And so if that means that that a group of our staff, our employees, our colleagues are going to perhaps have more absences over a period of a few years, how can we frame it that we care about their productivity? I will give you the example I gave to my Mayo senior. And again, I have a big organization. We're a research organization. And so the example I would give that was, why should you care? And this is, you could come up with your own for the department or division chair, is, okay, we've got two young, bright cardiologists, and they both at age 35 get an RO1. Over the next 3 years, both he and she have 2 children. Now, he took some parental leave, a couple weeks with each child. She took 6 to 12 weeks because of recovering from birth. At the end of that 3 years, when that RO1 is coming up for renewal, Mayo Clinic, right? Because it looks good on us if we get 2 more RO1s. We want them both to succeed. All right, if you step back and we all agree we want both of them to get their RO1s renewed, what might we put in place to support her that might be different than what he needs, that we can make sure that she is competitive? Now, that's a very simple thing, but I think most people at the end of sort of saying, well, yeah, we would want both of them to succeed. And so I think, yes, things are politicized, but I think at the heart of things, we want everyone to succeed. And sometimes at different stages of career or stages of life, some people need a little boost, a rest, or something to make sure that they get over the humps. And figuring out ways that we can all do that, that is kind of equity. You know, speaking of diversity, I don't like the word particularly, not because I don't think it's important, but the root of the word diversity is pointing out differences, right? That's diverging. And I think it's an important word because it does help us categorize. It's just one that is very polarizing to individuals who hear it. But the other fact, and I think, again, it gets back to our patients, is there is a fair amount of evidence, not so much in cardiology, but in primary care and in hospital medicine, that having concordance by race or gender between patient and provider can improve outcomes. You know, for me, I'm not going to go around saying that women provide better care, but I will say early in my career, there was a great deal of concern that women would provide grossly inferior care. There was that bias. They're not committed. They took a place, in medical school away from a man. They have no right to be here. And now we have a number of studies that have come out, and not only do women have equal, but in some cases, very slightly better care. And we don't understand what that is. You may spend more time with the patient, or, most of these are from administrative databases. But we all come to the world with some biases about how some group that isn't currently part of our workforce might impact that workforce. And I will say, I heard my parents, not about me so much, but about their peers, talked about women who were in medical school 50 years ago, taking away a place from a man. And that has clearly changed. We have, for the past 4 years, we've had more women graduating from medical school than men by just a hair. But I think we could talk about this a long time, but I think the way it seems to resonate with people is give real life examples of why don't we want all patients to have the same outcomes, right? It's equity in outcomes. And maybe that means we get them more or less drugs or different drugs or use different testing. If we switch to the workforce, then it's the same thing. Don't we, if we're aspirational, hope that all people will be successful, excellent cardiologists, excellent nurses, excellent team members? And if we start with that, then we can start being creative about, well, what does he or she need to reach that goal? And it will be very individualized. I may sound like Pollyanna in some of this, but I actually see how when you start with a desire for equitable outcomes, whether it's clinical or in the workforce, you get really creative. And then when you talk about diversity, there's a fair amount of data that says that diverse teams make better decisions. Those decisions are not without more conflict, and they take longer, but they're better.
Yeah, no, I could just sit and just listen to you. It's such it's thought provoking. It's sort of pushing the envelope. It's also very meditative. So thank you for sharing your insights. I have a question, and I'd be curious to listen to your thoughts, or certainly learn from you. And that is, I've sort of come to think of diversity as the diversity phenotype and the diversity genotype. The phenotype is that, yes, we come from different cultural backgrounds. We've got different upbringing. We were born and bred in different places in the globe. And we have different sets of biases. We look different. Our, maybe the color of the skin is different. The way we dress is different. Our religion, or, from a spiritual perspective, some of the beliefs and spiritual practices we follow may be different. And that's one aspect of diversity. So I call that the diversity phenotype. The other is that we could all be very similar looking, have similar religion or similar spiritual beliefs, eat the same kind of food, and just have like diversity of opinion or diversity of thought. How do you, one, parse the two out? Because I think, and vice versa. I mean, you could be from totally different backgrounds, still have very aligning, views on the world and topics, within cardiology and outside of cardiology. So that's one. So how do you parse the two out? And then how do you inculcate or encourage, diversity of thought in your existing faculty members, or, when you're recruiting, or even when you're advancing, faculty to, leadership positions within your organizations, and or maybe if you're, consulting with organizations like the American College of Cardiology, for example.
Yeah, that's so those are two related but different. So I think your first aspect is really talking about, one way to think of it is the dimensions of diversity that we all have. And there are some that are fairly fixed, right? Perhaps your skin color and your sex and other parts of it. And then there are experiential. Am I a parent or not? Am I a military veteran or not? Do I have a physical or other disability? If you start thinking of all the dimensions of diversity, there's dozens. And I think that whether you really want to parse it out, I don't know about that, but I will tell you that the biggest trap that I could fall into is assuming that another middle-aged white woman had similar opinions about things, or that I would say, if she's a new acquaintance, that somehow we would gel, or particularly in healthcare, that a patient who looks and acts and has the outward appearance of being like me, somehow I would have some connection with her. That's actually I think, a great danger, because then we don't recognize some of the differences, and we don't go in with as much caution, perhaps. If I make a bunch of assumptions about this patient sitting in front of me who looks like me, I may miss the big picture. So I think being aware of differences, and as you said, somebody who came from the same city and talks like I do, and is got the same profession and is about my same age, may have just markedly different things going on in their head or in their private life, right? I mean, again, it's not visible that somebody is LGBT, or that they are a parent, or that they served in the military. And all of those things inform who we are. And so thinking about those large numbers of dimensions of our own diversity and our culture can help us navigate the world. And I think, to your second question, is how do we mindfully make sure that we are, whether it's aware of diversity, that we with intention build diverse teams. And as you said, diversity doesn't mean that you've got, oh, we got a white guy and we got a black guy and we've got a white woman and we've got an old person, we've got somebody in a wheelchair. That's, yes, it's diversity. But if everyone on that team has the same skill sets and thinks kind of alike, you can end up without the desired effect. The other part, say you have a really diverse team, and in fact, the team all thinks really differently, but you don't allow inclusion of every member of that team. So that gets to the inclusion part. Then, as intentionally as you may have been to form that team of smart, diverse thinking people, if you then marginalize two or three of them because maybe they're piping up with an idea that sounds kind of wacky, but it might be the right answer, right? So that's where the inclusion part comes in, is we can have diverse teams, we can look diverse and not benefit from that diversity. And in fact, we can cause harm, because if we say, we hired you for your diverse perspective, we hired you because we realize that we have a large African-American population and we have no African-American cardiologists or APPs. And so, but then we make that person that we have hired fit into the mold of our organization and walk the walk of that. We've probably failed them and we've failed us, because we probably will not achieve our goal.
Yes, I thank you for helping me sort of understand these better. Certainly understand diversity better. That's a very insightful response to some of the questions I asked you. I know it was a two-part question, and I think it's given me a lot more. Certainly, it's given me a lot more insight as to how I think about diversity, and sort of has highlighted some of my own biases as I've come to think of diversity. Because I know we both agree that it's an important topic. It's a complex topic. It often, unfortunately, in the current scenario, has garnered debates and attention. I do think that as clinicians, and particularly for you as a leader in a reputable academic medical center organization, a research organization, this is a clearly important concept to be very comfortable with. The final section of the podcast, Dr. Hayes, I want to focus on some of the really interesting work that you've done and you've published, and I think it sort of also falls under, what you do now, which is, academic advancement and faculty development, and is something which resonates with me personally. So I have a personal interest in discussing this with you. Two papers, and I think what we can also do is for the listenership, who are interested in looking at these papers, I certainly enjoyed reading them as I was preparing for this podcast. Two papers where Dr. Hayes is a co-author. One is adopting academic rank in a rural community practice affiliated with an academic medical center. A position which I'm in now. I have an adjunct position with the School of Medicine at Indiana University School of Medicine in their West Lafayette campus. As I'm in a position where I'm fulfilling my waiver obligation, as I came into this country on a J1 visa. I have trained in places and, built an academic portfolio for myself, and sort of was in a bit of a conundrum when I wanted to balance my waiver obligation with my academic interests, and was looking for pathways to be able to do both. I think a similar concept as to what you've described has worked well for me. And then I think in relation to that, pursuing academic promotions, because I have pursued academic promotions whilst still being a full-time clinical, FTE1, and I've been successful in them. However, have found out that the process is rather onerous, and have known colleagues who have reached out to me asking about tips and sort of guidance and direction and pathways as to how to do this more efficiently, because just accruing all the paperwork to go through the process is rather onerous. So if you can help us, well, for the first one, how did you come up with such an interesting paper on adopting academic rank in a community practice? That's one. And then if you can highlight or shed some light for the listenership, and I know this is going to garner a lot of interest because I've received, personal inquiries myself, is how do you go about preparing your application packet together for an academic promotion?
Yeah, well, I'll start with the paper. I will. I'll give due credit to my colleague, also a cardiologist, Andy Calvin, who was the first associate professor in our community practice, and he's full-time clinical practice, trained here at Mayo, but also knew that's something he wanted to do, and he helped set up within we have 4 regions that are community practices in Minnesota and Wisconsin. And those are full-time clinical practices. They sometimes collaborate in a small way with folks in Mayo and Rochester, but that had not been part of their culture. You have to think about what your culture, and I'm going to come back to that. But if your culture is just take care of patients in the office and in the hospital, and there was never any expectation or even opportunity for you to achieve academic rank, then when that opportunity becomes available, what are you going to do about that? And I can tell you what did happen. There was a group of folks, physicians practicing in these 4 regions, who basically felt like, gosh, the rules have changed and it's unfair. I don't want this. Nobody told me I had to do this before. Now they're just telling me I have to do something extra. So I think the lesson there is that among those who have an initial negative reaction, because it's yet another burden, perhaps, you either you're going to need to help show them the value proposition. And here at Mayo, we do not get any additional compensation for any rank, including full professor. So that's not one of the incentives we can offer. And so there were people like Andy Calvin and some other colleagues who either already had some academic rank, they were instructor or assistant professor, and they had benefited from it. And they went about actually talking with their colleagues, setting up an educational program that was both, what is it? Why should you care? And here's a pathway to do it. And they actually because of this, they actually influenced a change in the assistant professor committee to make it actually easier, which also helped those of us who are in Rochester, Minnesota, Arizona, and Florida. So it was this pretty grassroots. So it came a bit from high that, like there's somewhat of an expectation that all of you community physicians should seek academic rank. Some of them were in their 50s and 60s, right? They never thought of themselves as academics. Now, you saw in the paper, though, that after this was put in place and there were some early successes and they got the process down, that then there was an excitement. Actually, many of the individuals who achieved their first academic rank, they were really proud of it. This is another way to show my leadership. This is another way to show, to learn about things. This is another way to organize my accomplishments. And wow, I've really done a lot. And now they're recognizing it. So, I will take little credit for the actual process. And I will look to those in the grassroots who got their leadership at each of these four major sites to help facilitate this. And one thing that I was very involved in early on was there was in our Eau Claire site, there were a number of women, none of whom had academic rank, all of whom were primary care physicians. These were internists and family medicine docs, and they were just darn excited about the prospect of achieving academic rank and progressing their career. And they got together and decided to put on a full day seminar. I got engaged and I've taught it. It's now become annual and they sell out. And this is regional. People now, this site is about 2 hours drive from Rochester, and there's people from Rochester that drive over to this. But the whole, I watched as over the past 4 or 5 years as this group of 5 women who put on the Wilma conference. At first they were very, let's just teach women what academic rank is. Let's have our top institutional leadership. And then they bring in people like me who could help talk about the why. It has become something that hundreds of women from across the enterprise now participate in every year. So I think when you frame academic rank as something that is appealing, that is personally gratifying or develops me, or for whatever the incentive there is, that's the first part, because making people doing or them seeing there is no value. Now, I know you, Ankur, you see the value in it. And so I'm going to flip over to, your second part of the question is, what advice might I have for individuals who are struggling a little bit? They don't, where do I start? The first place to start is on your organization's, whatever they call it, the, promotions page, their academic advancement page, their web page, that even if it's kind of bare bones, start looking at the process. That's where you start. I have seen so many people do, including me early in my career, spend lots of my discretionary time on doing a certain activity that we think is really important, and then find out that our organization doesn't weight that very heavily in academic promotion decisions. Each organization is different. I am fortunate, and I sort of encourage this, but we actually put together, and I'm not on the committee, the institutional committee, but the committee put together a grid of activities and roles that were heavily weighted, medium weighted, or barely weighted. Well, I had written some book chapters. I'm a really good writer. I'm a really slow writer. So I had written several book chapters, my gap early in my career, and I kept getting capped to do that because I'm a good writer. But they take a lot of time. And I then learned that Mayo, in their criteria, doesn't value book chapters. It's much, much lower than a first author paper or even a middle author, independent research or scholarly work. So what I I made decisions with that knowledge that, you know what, I'm not writing another book chapter unless it's really special. I'm going to focus on something else. So first is get whatever resources you can from your organization. Each one is different. My advice to you is going to be generic because your organization isn't going to have the same criteria. Second, know the criteria and what are the things that they are really looking for. I think the third thing, and it could go as an equal number one, is keep your CV current. It's really easy to forget to add that talk that you gave. You're going to remember, the paper that's got a PubMed citation. You're not going to necessarily remember all the talks you gave or the committees that you sat on at 2 employers ago, or maybe it's that leadership role you had at the ACC back when you were a fellow. All of those things should be. So if your CV isn't up to date and you are at all considering a future academic appointment or getting academic rank, keep your CV, make it a habit, check in quarterly. If it's an online at our organization, we have to enter all of our stuff into a platform, print it out or at least look at it online in a Word document at least once a year and make sure everything's there. If you say you have done all of that and you're now an assistant professor, the biggest gap at every organization is between assistant professor and associate professor. It's usually a bigger gap in terms of publications or, many have different tracks. Maybe you're in a clinician educator track, or maybe you're in a research track, but there's a bigger gap. But the other thing that almost every organization says for associate professor is you need to be known for your scholarly work outside of your organization, okay? People have to recognize the contributions that you have made in education, research, practice. And people forget that. They put their nose to the grindstone, they publish a bunch of papers, or they do a lot of administrative work at their organization. They're a top leader, but nobody knows them. They haven't given grand rounds at another organization. They're just, everything on their CV says they're a member of 5 professional organizations. They have never volunteered to be on a committee, much less a leader. When you hit associate professor, those things are going to be problematic because most associate professors and all full professors, they're going to look for referee letters from people outside of your organization. So most of them, it has to be somebody you've never worked with, that you did not train with, and in some cases have never written a paper with or have written less than a certain number. So think about that. I would say to those of you in your audience who are maybe assistant professors or think someday I might want to be an associate or full, think about who are your 3 to 5 people that you could name who aren't conflicted, meaning they didn't work with you, they don't know you, they didn't train with you, they haven't written a lot of papers with you, who could sort of at an arm's length say, yeah, this person is the real deal. Their work is important in education, research, clinical practice, whatever it is. And so what I tell when my junior faculty, when they come on, and even our fellows, I say, be thinking ahead. It might be 10 years, but now is the time to cultivate those connections, right? So if somebody invites you to give a talk at another organization or at another organization's CME course, well, that person must think enough of you, your speaking, your teaching, your expertise, that might be one of those 5. If you are a member of a committee for ACC, AHA, HRS, be a member of that committee and do all the work that you should be doing, be accountable, do a great job. That committee chair might be that person who you could be thinking about. If you're somebody who says, why would I go to meetings? Maybe you're an introvert. Maybe meetings are really hard for you because it's just hard. It's taking me away from my work, my family, whatever. I would say going to meetings and sharing your work and that networking is worth something, even if it's a bit hard. So I think knowledge is power, keeping your CV updated with all of the things, knowing what your organization cares about and values in terms of academic appointment and promotion. And then if you're set the stage now where you are strategic about making sure that other people know what you do and what your expertise is. And this doesn't mean bragging, but this does mean being able in your own head to say, I bring great value to the American College of Cardiology because I sat on 2 committees over the past 5 years, and this is what I did. I published this paper and it has an impact, right? So those are my basics because those would apply to pretty much anyone in the audience who is thinking about it. But the biggest thing is knowing what your organization values, because this is a goal. You don't want to spend a lot of time doing things that don't count.
Yes, wow. That was just incredible. I mean, I think it's just a completely new insight into what goes on when your application packet is being evaluated, by someone who sits at the table like yourself and sort of evaluates these applications for promotion. This has been a fascinating conversation. I really applaud you for sharing your knowledge with our listenership and sharing your research and all that you've done and continue to do. Both, and we haven't even delved into some of the amazing work that you've done in advancing the science in women's cardiovascular health, particularly spontaneous coronary dissection. Maybe that's the topic for another episode. But this has been a fascinating conversation. Thanks again for doing this for us. Any closing remarks for our listenership and for Parallax?
Well, first, thank you for inviting me. It has been a pleasure. Second, for those who are listening and perhaps have felt frustrated at their organization, either because of lack of flexibility or not understanding why they're not getting where they want to go in the organization or academic advancement, there may not be somebody like me with a specific title, but use your resources locally, because seeking out people and letting people know what you need is probably that first step. I do know that sometimes, particularly folks who are more junior in career or fellows, they don't want to tip their hand about what they don't know. They feel like they should know everything. And if I had to give advice, is none of us do. I still ask for help. And I would just say there's probably somebody who is in your network who could, if not give you the answer that you need, direct you or connect you with someone who can. And don't be afraid to ask.
Excellent. Well, thanks again for being here and for being such an eloquent guest. For our listeners, thank you so much for tuning in and for listening. We do value your feedback, so share your feedback with us on SoundCloud, Spotify, or Apple Podcasts. Email us and even with suggestions on who you want to listen from. And until other Monday, thank you for listening.
We hope you enjoyed today's podcast, produced by Radcliffe Cardiology in association with makeadent.org. We aim to bring you a new angle of all things cardiology every second week. Review us on your favourite podcast app or send your comments or questions to podcast@radcliffe-group.com. To view the series, head to radcliffecardiology.com/podcasts/Parallax. Thanks for listening.